So today we'll be going over a simple primary care review on borderline personality disorder. Borderline personality disorder, also known as BPD, is defined as instability of interpersonal relationships, self-image, and emotions, as well as impulsivity across a wide range of situations, causing significant impairment or subjective distress. The clinical course of the disorder is that the onset of BPD occurs in adolescence or early adulthood and has a chronic course over the lifespan. DSM-5 Diagnostic Criteria. BPD is indicated by 5 or more of the following. 1. Frantic efforts to avoid real or imagined abandonment. Do not include suicidal or self-mutilating behavior covered in Criterion 5. A pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization and devaluation. 3. Identity disturbance. Markedly and persistently unstable self-image or sense of self. 4. Impulsivity in at least 2 areas that are potentially self-damaging, such as spending, sex, substance abuse, reckless driving, or binge eating. Note, do not include suicidal or self-mutilating behavior covered in Criterion 5. 5. Recurrent suicidal behavior, gestures, or threats, or self-mutilating behavior. 6. Affective instability due to a marked reactivity of mood, such as an intense episodic dysphoria, irritability, or anxiety, usually lasting a few hours and only rarely more than a few days. 7. Chronic feelings of emptiness. 8. Inappropriate, intense anger or difficulty controlling anger, such as frequent displays of temper, constant anger, or recurrent physical fights. 9. Transient, self-related paranoid ideation or severe dissociative symptoms. Clinical manifestations. This includes impaired relatedness, which are unstable relationships with others, identity disturbance, and chronic emptiness. Affective dysregulation, affective lability, excessive anger, and efforts to avoid abandonment. Or behavior dysregulation includes impulsivity, suicidality, and self-injurious behaviors. Suicidality. This includes suicidal threats, gestures, and attempts, which are common manifestations of BPD. Assessing the current risk of a patient's suicidal intent is difficult. Years of suicide threats and self-injurious behavior may precede a completed suicide. Interpersonal difficulties. Patients with BPD usually have stormy relationships, especially with people to whom patients are close with. At one moment, a friend or romantic partner may be viewed not only as a trusted confidant, but as an ideal, almost perfect person. And then, this same individual can suddenly be seen as cruel, betraying, very limited, and damaged. Patients tend to view others as all good or all bad, a phenomenon that has been labeled as splitting. Affective instability. Patients experience repeated and marked mood changes throughout a day, often triggered by environmental stressors. Periods of euthymia can alternate with intense episodic dysphoria that includes depression, anxiety, and irritability. Angry outbursts triggered by dissatisfaction with a caregiver are often followed by feelings of shame, guilt, and worthlessness. Impulsivity. Patients can abuse substances, binge eat, engage in unsafe sex, spend money irresponsibly, and drive recklessly. In addition, patients can suddenly quit a job that they need or end a relationship that has the potential to last. Impulsivity can also manifest with immature and regressive behavior and often takes the form of sexually acting out. Cognition. Neuropsychologic functioning in patients with BPD is impaired in many domains: attention, cognitive flexibility, learning and memory, planning, processing speeds, or visual spatial abilities. Self injury. Patients may engage in self injurious behavior that is not intended as suicide, such as cutting or burning themselves. Patients may feel that the relief of tension provided by self injury. Psychotherapy. First line treatment for psychotherapy includes dialectal behavior therapy, mentalization based therapy, transference focused therapy, good psychiatric management, cognitive and behavioral therapies, or schema focused therapy. Dialectal behavior therapy are for the most regressed patients or for those with high levels of self destructiveness. DBT focuses on increasing coping skills and tolerance of unwanted or previously intolerable affect, and much self destructive behavior and acting out behavior appears to be triggered by or being overwhelmed by affect, which is emotion dysregulation. Thank you.